And we'll like groups of maximum 15, because we don't think there are more than 90 people here. If there are more than 90, we'll add on an extra. So before we go for lunch, only for those who think they are going to come back after lunch, please. If you think you're not coming back after lunch because you have a flight, then please don't put your name on the paper. It won't count against you, but don't, because it will just create logistical problems for us. Yeah? So we'll go through these lectures, again, 20-minute lectures, starting on the shoulder and working downwards. And then before we go for lunch, don't head off. If you're coming back, we'll have the papers 1, 2, 3, 4, 5, 6. Junior guys here, senior guys here. Okay? Is that clear? Any questions on that? Pardon? Okay, I'll repeat again. So guys, for those of you who've just come in, I'm just going to repeat what I just said, yeah? We're going through the upper limb session now, okay, lectures of 20 minutes. Before we break for lunch, those of you who are only coming back for the afternoon section, so if you have a flight to catch, yeah, don't put your names down. So we'll be having papers, three sets of papers on this side, 1, 2, 3, 4, 5, 6, yeah? Those who are junior guys, so core trainees, senior guys just for the exam, write your names on the papers here, but only put your name on one piece of paper. And if you have friends here, you want to be with them, please put your name, group together and put your names on those papers. Now, maximum 15 candidates on one piece of paper. So if you get to that paper and it's 15, go to the next one, okay? So we'll do that just before lunch, so that when we come back after lunch, we can go into the groups and then practice what we've learned this morning, because practice makes perfect. Okay, so we'll start off with examination of the shoulder, and there's no better person than Mr. Shantanu Shahani who will go through this to teach us how to examine the shoulder. I'm also going to learn from him, actually. Thank you, Shantanu.
Ladies and gentlemen, good morning again. I'm Shantanu Shahani. I work at Chesterfield. For the next 20 minutes, we will plan to go through the shoulder examination. Should be, I think. It is, yeah? No? I think so. Next 20 minutes, we'll go through the shoulder examination. This should do enough for you to go through the exam, but more importantly, for non-shoulder surgeons, this basic shoulder examination should be enough for you to carry on working in your fracture clinics and so on. Important thing is to go through all the steps. We will talk about them just now, and then we'll go through all of those again in the afternoon many times for you to reinforce the thing. Richard is one of our F2s. He's very kindly agreed to be a model for the exam. I can't show a shoulder examination just by slides like my colleagues can, so I'll just ask him to help us out. So this is what we will be going through. First, three things are very simple. We'll talk about this. Then the rest is normal format. We follow look, feel, move, and these are the special tests. And then we'll finish with thoracic outlet syndrome, a few tests for that, and neurovascular status examination. Before coming to the inspection, Richard, can I just get you here? Just take the top off for me, please. Just take the shirt off for me. Exposure of the patient for a shoulder examination is absolutely important. And we will see in the exam that sometimes you will have a fairly major issue with a hand problem or something, and if you don't expose all of the shoulder, which means most of your chest from the front all the way around from the side, it is extremely important to be able to do that. Thanks, Richard. So unless you're able to see all of the shoulder from the front side, it is not acceptable. Now, it's very important in exam to preserve modesty, especially if you have female patients. They should not feel uncomfortable, and you will get special gowns, etc. Just make certain that the patients are not uncomfortable throughout the examination. Okay. Stand the patient. All of the shoulder examination is done in a standing position, except, to me, the only test, which is an apprehension relocation test for instability, it's done in a lying down position. That's the perfect position for doing that. You can do that in a sitting position, which we can show you later if you don't have a couch in the exam, okay? When you make the patient stand, it is very, very important that you can have a 360 view of the patient, because a large proportion of your shoulder examination is done from the back, and you have to be able to see the scapulothoracic joint. And if the patient's standing right close to the wall, you will completely forget to look at the scapula sometimes. And rather than telling the patient, now you turn around, then you turn back again, that creates confusion. So just make certain that you can walk around the patient for examining. And then comes screening the cervical spine. We are not doing a neuro exam here. So I do a very quick screen of the cervical spine. Why is that important? We know a lot of pain around the trapezius area can come from neck, but also the suprascapular nerve innervation comes in this area. So we want to have a very quick screen to see if there is some contribution to the shoulder pathology to the neck. And it's an extremely simple screen. Just look towards me. Stretch your chin to the chest. Look up straight. Look this way. And the other side. Ears to the shoulder. On the other side. While doing this, if you get some radiation pain, some referred pain, the patient complains pre-consultation to tingling in the hand, then you have to do a full neuro exam. And you have already been shown how to do a spine exam. And that's very, very quick cervical spine. You only tell this in the exam so the examiner understands that you understand there can be a dual pathology to the shoulder. A C5 problem can create a lot of deltoid and referred pain. So it's just to explain to the examiner that you're aware that there can be a dual pathology. And then we come to the shoulder examination. For examining the shoulder, you always look from the front. What are you looking for? You're looking for the deltoid contour. You're looking for the skin condition to see if there are any scars. Arthroscopy scars are right in front. The deltopectoral, the commonest incision is right in the front. Look out for that. Sometimes you have stretch marks which obliterate your deltopectoral incision. So look out for that. Look out for bony prominences. And it's important to mention negative findings. I have seen sometimes in Richard's case, because there is nothing abnormal to see, people just keep looking, keep watching. They don't say anything. If you don't say a negative finding, the examiner doesn't know if you know what you're looking for. So it's very nice to just say, the shoulder contour seems normal. There are no obvious scars or swellings. The sternoclavicular joint, the clavicle, and the ACJ seem normally aligned. Looking from the right side, again, there is no obvious abnormal finding. Looking from the back, the thoracic kyphosis is normal. There is no winging of the scapula, and there is no wasting around the supra and infraspinous fossas. There are no obvious surgical scars. And have a quick look and say the axilla seems okay. Why is axilla important? Once I have seen a transcervical rib resection or say lymphadenopathy, it just is like a popliteal fossa of the knee, which you forget if you don't turn the patient over. And you may find a lump, a Baker's cyst. Similarly, you may find a lump in the axilla. So it's very good for completion to finish it off now so you're not forgetting it. And this was the advantage of being able to walk around the patient. Therefore, you have seen the front, back, and sides. And if you see something, say it. If you don't see it, mention the negative finding. That's very useful. And this is just to show you wasting around the fossas, prominent AC joint, loss of deltoid contour, infraspinous fossa wasting. So it's just an example of somebody whom we were planning to do a cuff repair, just preoperative picture of that. Palpation. People palpate all kinds of, you have to be having a logical reasoning as to why you're palpating something. So I just do 3 or 4 areas. Feel the sternoclavicular joint, feel around the clavicle and say there is no evidence of clavicular malunion. ACJ tenderness is very important. It's the most diagnostic test for an ACJ pathology. So if you have an ACJ tenderness, look at the patient, see if it's painful. Greater tuberosity tenderness is useful just sometimes in cases of impingement. So at your level, you need to be able to say that. And sometimes people look for this parascapular tenderness. I don't think in exam it's relevant. And then confirm your findings of inspection. So if you have seen a clavicle malunion during inspection, confirm that. It is non-tender, it's malunited. Sternoclavicular joint is dislocated. So just expand on palpation what you have seen during inspection process. Now this is where sometimes things start going wrong. When you want to elicit a certain movement from the patient, the best thing to do is to do it yourself and ask him. In the exam, we see all kinds of things. People say, can you just flex your shoulder? Can you rotate your shoulder? The patient has no clue what you're talking about. So the best thing to do is to tell the patient what you want to do. Just step back a bit. Palms out. And just lift it straight. Just follow me. Lift it straight up. So Richard has a full range of painless motion in both shoulders from 0 to 180. Come down. Sideways. And keep going up. And abduction mirrors a similar picture. Come down again. Now, if he stopped at some level, then try a little bit active assistance and passive. If it is painful, stop. So do active movements, active assisted and passive in the same go, okay? You have still not gone to the back of the patient. You don't need to, and I'll tell you why. Flexion and abduction is initially done actively, but external rotation is only done passively. You don't want active external rotation. Just put the elbows by the side and just have a look how far his arms rotate and mention that. Limited external rotation in a non-traumatic condition is either frozen or an arthritic shoulder. And the differentiation between the two is by an X-ray. So as soon as you have reduced external rotation on one side and there is no traumatic history, these are your most two commonest likely diagnoses. The shoulder is either capsulitic or frozen, or it is arthritic. And you distinguish them by an X-ray. Arms behind, as far as you can go. Just turn around. This is a good way to check for internal rotation, how far the thumb goes, and you can talk about the spine of scapula, inferior angle of scapula. This is a functional internal rotation. The true internal rotation is this movement, which is never needed for function. Whereas your functional internal rotation, that's fine, involves extension of the shoulder, flexion of the elbow, internal rotation, CMC and wrist movements. And you can explain that to the examiner, that this is not true internal rotation, this is the functional internal rotation, which is what you need to know. Because people need this for hygiene, dressing, and all other purposes. And while you're doing internal rotation, you can stay at the back of the patient. Just lift your arms straight up again. Yeah. And come down. And lift the arms in front. And you can examine the scapulothoracic rhythm. Come down. And you can mention to that during flexion and abduction, the scapulothoracic rhythm was normal. Just turn around. So what have I done? I've done flexion, abduction from the front, external rotation, internal rotation, then I've gone back, I've stayed behind, and done flexion and abduction again to look at scapulothoracic rhythm. So in one movement, going around the patient, you've finished range of motion completely. Scapulothoracic rhythm contributes to about 1/3 of your total arm elevation. So approximately if somebody asks you 180 degrees, 60 degrees will be scapulothoracic in varying degrees. But about 120 will be glenohumeral and 60 will be scapulothoracic. Okay. These are just to show you flexion, external rotation, and internal rotation. Now we come to impingement signs, okay? There are 3 impingement signs. All 3 signs are passively done. An impingement test is not done actively, which is Nears, Hawkins, and Scarf. And you can do all 3 in one sweeping motion, okay? Nears sign. Left hand, if you're examining the right shoulder, left hand stabilizing the scapula, right hand over the wrist, turn the arm internally. You're getting the greater tuberosity right underneath the coracoacromial arch, and then you're gently lifting it in the scapular plane and looking at the patient. If he's exhibiting any signs of pain, that is Nears sign. When you've gone up and he's not painful, you keep your right arm where it is, left arm comes here, and you bend the elbow, and you look for Hawkins. You're trying to nip the greater tuberosity underneath the rotator cuff, underneath the acromion. You've still not moved your right arm. You move this here, take it across, press it, and see if patient gets a problem or pain on the top of the AC joint, which is your Scarf test. In one sweeping motion, you do all 3 impingement signs. Again, repeat. Nears, arm straight up, come down, come here, Hawkins, arm here, across, press, look for pain on AC joint. Nears, Hawkins, ACJ Scarf test. In one, it's a 15-second, you can do all these 3 tests. The impingement test is completely different, as we well know, and this is something we do in the clinic. You inject local anesthetic in a painful subacromial bursa, and these signs, well, the first 2, become negative. That's your Nears impingement test. Is that clear? These 3 impingement signs are easy. You should know what you're doing here, though. But at your level, you need to know what are you trying to do. With Nears and Hawkins, you are trying to catch the rotator cuff underneath the coracoacromial arch. With the Scarf test, you're trying to compress the AC joint, but you're looking for pain at the AC joint. So it's important to go that one step further. Why am I doing this test? What is it exactly eliciting? This is the commonest thing you'll be asked in the exam. You need to know how to examine for the cuff. What is the prerequisite? You can't have severe pain. If you have severe pain in the shoulder, you can't examine for the cuff because all signs will be positive. It's pain inhibition leading to weakness, not genuine or true weakness. And secondly, they should have reasonable passive movements. If you don't have enough passive movements, you can't elicit signs. So there are 4 tests. Let's do the supraspinatus first. Arms out in the scapular plane at about 40 degrees. There's a lot of debate. Should it be 30, 40, 60, 90? It's at about 45 to 60 degrees. Hold it there. I'm going to push down, try and stop me. And he's holding it there, and it is not falling down. Empty can test negative. Why this position? When I lift the arm in the scapular plane and turn it fully internally, I'm trying to distinguish the deltoid movements from the supraspinatus strength. And by rotating the arm internally, I'm taking the deltoid tuberosity here. So I'm putting the deltoid at maximum disadvantage. But I'm getting the supraspinatus in absolutely straight line. So I'm putting the supraspinatus in maximum advantage. That's the best you can do. You can't eliminate the 2 muscles completely. But this is the best way you can take the deltoid out of the equation and put the supraspinatus at maximum stress. You don't push here. You don't press here. Why? The triceps will compensate for absent supraspinatus. So you push above here. So you eliminate triceps to the best of your ability, and then see if it stays there. If it's a large tear, you will get a joke test positive, arm just falls down. If it's a small tear, you may have to press, no pain, it falls down, supraspinatus is most likely gone. If there is pain, you give local anesthetic, eliminate pain, and then do the tests. Okay? The next three tests, the infraspinatus, teres minor, and subscapularis, can be done in one sweeping motion again. What does the infraspinatus do? Infraspinatus is an external rotator of the arm, external rotator of the shoulder with the arm by its side. My one hand is here, and this is on the thumb. I'm holding it like this. And this is what the infraspinatus should maintain. If I let go of this and it falls down, a large tear of the infraspinatus, lag sign positive. If it is not falling down and I have to push, try and stop me. Is holding it tight? You can feel for the infraspinatus, but that's not often necessary. Infraspinatus is intact. I've not moved this yet, so I'm holding it here. I'm abducting the shoulder. Teres minor is an external rotator with the arm abducted. That's the job of teres minor. Hold it there. If it falls down, hornblower sign positive. If it doesn't fall, I'm going to push it, Richard, try and stop me. Good teres minor. My hand is still here. I've not moved it. If the pain allows, go back. Turn around for me, please. Push my hand away. Subscapularis, lift-off test. What exactly happens in the lift-off test? Why is this important in the lift-off test? If the subscap is intact, it is holding the humerus in an internally rotated position, so the fulcrum is stable. And as the humerus stays internally rotated, if that is stable, he can then, Richard, push me away, he can do this. As soon as it tries to do this, if the subscap is not working, the humerus externally rotates. And what does he do? He can't lift it, or he bends his wrist. So that is cheating. So you need to know why this Gerber's test of lift-off works. Turn around again. If this is too painful, then you put the arm in front, elbows out. Again, the humerus is being held in internally rotated position by the subscap. I'm going to try and press it to stop me. He can only hold this here and this arm to stop falling down if the subscap is working. If it is not, the subscap lets go, arm falls out, humerus rotates externally. Belly press test positive. Is that okay? So infraspinatus, teres minor, and subscap in one go. Infraspinatus, teres minor, subscap at the back. All three in one sweeping motion. Okay. There you go, supraspinatus empty can, lag sign, hornblower sign, lift off, and belly press test. Okay. Yergeson speed tests are completely historical. You don't need that. Yergeson is resisted supination, speed is resisted flexion. This is for biceps tendinitis. It's purely historical. They're very poorly sensitive and specific, and they're irrelevant for me. I don't think anybody should ask them. If they ask them, you can read about it. O'Brien's test is fantastic for a slap lesion. Do we need this in the exam? I don't know. We'll teach you. It's an easy test to do. Arm in front, 15 degrees adduction, internal rotation. Hold it there. I'm going to push down, Richard. Try and push up as hard as you can. No pain, and you can hold it. If this is painful, and I turn it outside, now push up, pain goes away, slap testing positive. So what is exactly happening here? When you adduct the arm here and internally rotate, the biceps is attached to the top of the glenoid. So it's holding it. If you have a slap lesion, the biceps has come out from the glenoid. So when you try and load it, what happens? It tries to fall over the lesser tuberosity on the subscap. Patient gets pain. That's the first part of O'Brien's. Is that clear? If I rotate it outside, the biceps relocates back onto the groove. It doesn't rely on its attachment to the glenoid top. Now I'm pushing up, push up, he's happy. That tells you the slap testing, the second part of it is positive. That means there is a mechanical structural problem in the integrity of the biceps tendon from the glenoid to the radial tuberosity. You've been told just now about Baton's hyperlaxity. You need to examine that. Selkirk sign, I will show you. Selkirk sign basically can be done in a sitting or a lying down position. You basically just pull the arm down, ask him to relax, and see if you get a little sulcus here. I'll show you a picture of that. It is not a pathological sign. Selkirk sign indicates ligamentous laxity. It's a physiological sign. It may be positive in both shoulders, and it may be entirely asymptomatic. Load and shift test, I'm just putting there. You will not be asked, hopefully, to demonstrate that. But the next one is important, apprehension relocation. Ideally, you need a couch on which to sit down, lie down, and examine that. What you need basically is the scapula to be stabilized. So here I can't stabilize the scapula, but if you have something here which stabilizes the scapula, you're looking for apprehension relocation for anterior instability. So imagine Richard's lying down and you're in this position. Take complete control of this arm. I don't know if you'll be asked in the exam to do that. And holding the arm, just gently start externally rotating and keep looking at his face. If he feels apprehensive, that's apprehension positive. Relocate this back. And when you do that, you need something to stabilize the scapula. And that's why you need some scapular stabilization in terms of a couch. And then you relocate this back, and he feels better. Apprehension relocation positive for instability of the shoulder. That's the only one you need to either sit down or lie down for the patient. And that's your sulcus sign here, and it's apprehension relocation. This is exactly how it should be done because you can see the shoulder scapula is stabilized. You should be able to test the other muscles. My colleagues will be giving you talks about how to examine these three muscles from the front and these three muscles from behind. That comes more in the brachial plexus examination. Finally, thoracic outlet syndrome. Is that important? Yes, sometimes you may get a cervical rib or you may have a ligamentous band around the first rib which may cause thoracic outlet syndrome. So you need to know the two tests, Adson's for the vascular component and Roux for the neurological component. It's a rare thing, but you need to be aware of it. So if I imagine he's got a cervical rib on the right side, I've got my arm on his radial pulse, look towards me this way, yeah. Neck turned the same way, hyperextended, take a deep breath and hold it. And if the cervical rib is there, the subclavicular space is obliterated. Let go. Thank you. If your pulse vanishes, it's a vascular component of the thoracic outlet syndrome positive. And the neurological component is debatable. Basically, you hyperextend and hyperabduct your shoulders, and you do this movement by which you reduce the subclavicular space and you create a neurological tingling in the hand. I have never seen that positive, but it's not a common feature anyway. No shoulder examination is complete unless you have mentioned something about the elbow, wrist, and hand. And I have seen some ridiculous things happen in the exam. We had a person who had a massive hand deformity, and he was asked to examine the shoulder, and he never, ever mentioned the hand, anything to do with it. Now, that is something you're seeing, obviously, as an inspection. So don't just be focused on the shoulder. Be focused on the patient. You need to mention that his opposite elbow, wrist, and hand is fine, his opposite shoulder functions fine, and neurovascular examination. So what did we do? We exposed the patient. We made him stand. We can walk around him. We quickly screened his cervical spine. Then we looked, palpated, and moved the shoulder. During moving, we did most of the movements from the front, went back to see the scapulothoracic rhythm. We didn't forget that. Impingement test, 3 tests, Nears, Hawkins, and Scarf. We did them in one go. Muscle examination, cuff status, empty can for supraspinatus, infraspinatus, teres minor, and subscap. Again, in one sweeping motion, the remaining 3 tests. We did the instability testing, which was in a lying down position, apprehension, relocation, Baton's, and sulcus sign. Thoracic outlet, we know the Adson's and the Roux test. And finally, a neurovascular status. Thank you. Show them it happens in one movement, so you can show them that you know it. But Hawkins is more specific for me. Nears can be played, is not as good. Hawkins is more specific. But it's useful to just show them. It takes 2 or 3 seconds more.
The patient between passive range of movement can mention and say I won't be able to do rotator cuff test.
Oh, you can say, because for a supraspinatus, you need to be able to elevate the arm to some element. For infraspinatus, you need to be able to externally rotate to some extent. I have not gone into the more details of it. Technically, if you have a reduced external rotation and you have an acutely frozen shoulder, all of the tests become irrelevant. Because all the other tests will be positive. Impingement signs will be positive, cuff will be weak, and they'll be false positive. But I don't want to confuse you with that. You need to be able to know what the tests are to do it, otherwise there may be potential for confusion.
Okay, just one point. Respectfully, we ask you not to video any of the demonstrations or the examiner. You can take pictures of the screen for copyright issues and so on. All of these things will be on Wikipedics, which will be part of BOA resource in the coming year. So you'll get all the video clips and all the lectures on that coming up, okay?
If you have taken videos, can you delete them? Because Richard Carey volunteered for a film, but he never volunteered in being filmed. So you have filmed it.
Can we be, yeah, gratefully, please delete that. Thank you.
So hi, I'm Ben Gooding. I'm from Nottingham, shoulder and elbow surgeon. We're going to talk to you about elbow examination. And I think in your training, you don't see many elbows. I certainly didn't see a lot in my early training. And people get really frightened of elbows, but it's actually the easiest joint to examine. If you get one in the exam, you should breathe a sigh of relief, because if you can't really remember what to do it logically, you'll get to the end very easily, okay? So we take a systematic approach, but not quite what you might expect. Stand the patient, as with much of your examination. Look at the patient, but then we move, okay? So rather than look, feel, and move, we're going to look, move, and feel, and you'll see why. It just makes the examination much slicker, okay? There are a few provocative tests, and there are some tests for instability, and that's it. So when you stand your patient and you look, as with all the examination, we're looking for the general things: scars, swellings, wasting, and skin changes. The alignment of the elbows, and I'll show you on the next slide what that means. And what I call a 360-degree examination of the elbow. And this is why you don't need to remember much. Just start somewhere and work your way around in a circle. So axial alignment of the elbows can only be seen with the patient standing looking from the front. The normal axial alignment of the elbow is somewhere between 7 and 15 degrees, as you can see on the picture on the left-hand side. Valgus elbows, I used to get mixed up with varus and valgus. I don't know whether you guys do or not. I just think of valgus as vulgar, going away, okay? So valgus elbows in the middle there, or a varus elbow as the elbow is on the right-hand side of the right picture. Around the front of the elbow, essentially, we're looking at the biceps. So those two pictures represent, I hope you'd recognize, on the left-hand side, a rupture of the proximal long head of biceps tendon, giving you a Popeye sign. And on the right-hand side, a rupture of the distal biceps tendon with proximal retraction of the muscle belly, okay? So they're two very different things. One's a rupture at the top of the arm, one is a rupture at the bottom. Looking on the lateral side of the elbow, essentially you're looking for swelling, which might be an effusion, or it might be a dislocated radial head, as you can see on the x-ray there, and skin changes. And people with tennis elbow often have thin skin discoloration from multiple steroid injections around the lateral side of the elbow. And then on the back of the elbow, you're looking for swellings and scars such as a bursa or nodules. And on the medial side of the elbow, so you've looked from the front, and we'll show you all this afternoon, and you can practice it plenty times. You've looked from the front, you've looked from the lateral side, you've walked round and had a look from the back, and then to look on the medial side of the elbow, rather than sticking your head in their armpit, which might be unpleasant for both, we then bring the arms up to the side, and you can look at the medial side of the elbow, and you're looking for a scar, essentially, because you're thinking, has this patient had some surgery around their ulnar nerve? Because that's likely what you're going to see on the medial side of the elbow in the exam. Okay? So now, with the arms up, so you've gone from this position, you've looked. You've had all look round. You've brought the elbows up to look at the medial side. And from this position, without changing, you're then going to move, okay? And do flexion and extension. Now, arms out straight is 0 degrees. People seem to get this wrapped around the neck and think that's 180 degrees, okay? That's 0 degrees. The normal range of movement is from about 5 degrees of hyperextension to 140 degrees of flexion. And if you do it in this position, you'll see it very easily. If you try and do flexion and extension with the arms down by the side, you'll really struggle, because if someone's got valgus elbows, for instance, they might hide a flexion deformity. So arms out to the side, 0 to 140 degrees, okay? You then bring the arms back down again and tuck them in and do pro and supination. So with the elbows tucked in and the thumbs up, sometimes people put a pen or a pencil in their hand, just do it with the thumbs, it's easier. From 0, you should at least have a 50-degree arc both ways, okay? Some people have much more than that. I can go about 80. Okay? So you've done this, this, and this. Arms down by the side, thumbs up, out and in. It's easy, isn't it? And then we're going to feel, and this is where we move into 360 degrees. So you don't have to be thinking about what's next. Just start somewhere sensible. And if they've got a painful elbow, start away from the pain. It's pretty unlikely you're going to have someone in an exam with a very painful elbow because you don't want to hurt your patient, okay? So in general, I would start laterally. And I'll just run you through quickly the things you're looking for, and then we'll take it step by step. So from the lateral side, you're palpating around the lateral epicondyle of the elbow, and you're feeling for pain, which might indicate lateral epicondylitis or tennis elbow. You're then palpating slightly more distal into the region of the radial head here. If there's pain there, you can pro and supinate the arm and feel for crepitus. And more distal in the softer tissue for PIN syndrome, okay, which is often overlapping with tennis elbow. We then move in a circle round the back to the olecranon. And when you feel the olecranon tip, you're feeling is there a bursa or nodules. And while you're there, you're going to feel for congruence of the elbow. And I'll show you that on the next slide. It's about the triangle between the epicondyles and the olecranon. So I'll show you that in a second. Then move round to the inside of the elbow. You're feeling for the cubital tunnel, the ulnar nerve. Is there pain over the nerve? As they extend and flex, does the nerve sublux up over the epicondyle? And if there is symptoms there, Tinel's test. Tap on it, gives you tingling. I just got some tingling then, so you can test me later. And the medial epicondyle for golfer's elbow, is there pain there? And if you find pain, we'll do the provocative test. Again, I'll show you that. And then as you move around the front, you're feeling for the biceps tendon, which is the hook test. Have you heard of that? You get your finger behind the biceps, okay? So we'll work through them one at a time now. So the lateral side of the elbow, you're feeling for tennis elbow on the lateral side. If it's tender, go straight to the provocative test for tennis elbow. Because if you don't, you'll forget. And you'll examine the rest of the elbow and you'll forget to test for tennis elbow. The provocative test for tennis elbow is with the wrist in extension and radial deviation. Resisted extension of the middle finger is what should be described. And what it'll do is give you pain in the lateral epicondyle, okay? And we test that with the arm extended. This is when we're looking at the olecranon at the back for the bony landmarks, okay? You put your finger on the olecranon on the back. You put your thumb and your middle finger on the epicondyles, and you should go from a straight line to a triangle. And that shows you that the elbow is congruent, which you can see on the picture on the right, okay? So when the elbow is flexed, you have a triangle between your fingers. When it straightens, they go into a straight line. And if you've got a rheumatoid arthritic patient with destructive arthropathy in the exam, you might feel that that's disrupted, okay? So it's not just about trauma. Then we're going to go, so we've gone lateral around the back, then we're going to go to the medial side. So to examine the medial side, as we said before, bring the arm out. You don't have your head under the armpit. You're feeling around the medial epicondyle for the common flexure origin and for the ulnar nerve. And in about 10% of people, the ulnar nerve will sublux, and that's a normal physiological finding, okay? And you'll feel it flip up over the epicondyle as you flex the elbow and then click back. And the patient might describe a clicking in the medial side of the elbow. And Tinel's test, you all know what that is. You tap over the nerve, gives you tingling down the ulnar distribution of the hand. If they've got pain around the medial epicondyle, then you're going to test for golfer's elbow, which essentially is the opposite of tennis elbow. So rather than having the wrist extended, you're going to flex it and resist it, and it will give them pain around the medial epicondyle of the elbow, okay? And then you're going to come round anterior and put your finger behind the long headed biceps, okay? There you go. Mine's behind mine now. Try it on yourself. You get it right in there. If you're struggling, you get to put the hand up towards their face and you can really get in and feel that that distal biceps tendon. So that's called the hook test. You can hang a coat hanger on it. Okay, so we've gone lateral, round the back, round the inside, and to the front, testing the provocative tests as we go. And then the instability tests of the elbow, okay, so the final bit of the exam. So essentially there's 3 groups of ligaments you need to test. There's the medial ligaments, the lateral collateral ligaments, and the lateral ulnar collateral ligament, which is a rotatory test, a bit like the knee. So the medial collateral complex, okay, there's a number of bundles, and essentially you're testing for valgus instability if the medial collaterals have gone, yeah? And I'll show you how to do that in a second. Then we've got the radial collateral ligament, where you're testing for varus instability. And then finally, the lateral ulnar collateral complex, which is posterolateral rotatory instability. And I think about that a little bit like an ACL in the knee, which is a rotatory stabilizer, because the test for it is a bit like a pivot shift test in the knee. So how do you test the ligaments? Now, this is the bit where you can look really slick in your exam, okay? Can I borrow you for just 1 second? You don't need to undress. You're already on YouTube anyway by now with all this lot of video. So, the key here, okay, when you're testing the medial ligament, if we test the ligament with the arm in this position, it's very difficult to control the elbow. And as I put valgus stress, so the first thing we have to do is unlock the bones. In extension, the bones gives you stability. So we unlock the bones by flexing to 30 degrees. If I test in this position, all I end up doing is rotating his shoulder. Can you see that? And you've got no idea about the stability of the inside of the elbow. So we've got to take the shoulder out of the equation in order to get a good test for the medial ligaments. So how are we going to do that? Rotate the shoulder to its maximum before we do the test. So we're going to unlock the bones. We're going to take the arm to full external rotation, okay? And then we're going to test the medial ligaments of the elbow, okay? And he's absolutely solid. Does that make sense? Do you want me to do that again? Okay, everyone's nodding their head, so it obviously made sense. The lateral side is exactly the opposite, okay? So we've got to internally rotate the shoulder in order to take out the internal rotation of the shoulder. And this is the one that people get a little bit mixed up with. Just do it in sequence, okay? So internally rotate the shoulder, and then you can test the lateral ligaments of the elbow. So the shoulder ends up in this position when you're testing the lateral ligaments of the elbow. Does that make sense? And we'll go through with that this afternoon. Now, some of your examiners, if you're doing the FRCS, might not quite be able to get their heads around this, so tell them what you're doing. I'm externally rotating the shoulder in order to remove false positives from this examination, and now I'm testing the medial ligaments. And they'll think, oh, that's clever. Thank you very much. You can sit down now. Now, the final one is posterolateral rotatory instability of the elbow. And the reality is, so that's what we've just said, you're not going to be able to test this very successfully in an exam because it often needs to be done under an anaesthetic in the operating theatre, because otherwise you'll dislocate their elbow in the exam. When you dislocate your elbow, it's a rotatory problem. Do you know this? So what tends to happen is there are stages of a normal reduced elbow, a radial head that subluxes with the ulna rotating away from the humerus, all the way through to a full dislocation. And what you damage is the posterolateral rotatory lateral ulnar collateral ligaments, okay? So when you dislocate your elbow, it's a rotation. Just remember that. And there's some great videos on YouTube in slow motion of people dislocating their elbows. You can see it happening. And how you do a pivot shift test is exactly how you would do a pivot shift test of the knee, okay? Essentially, you supinate, and I have to show you this afternoon individually, but you supinate to try and drive the radial head away off the elbow. Does that make sense? Okay, so you're supinating. You put some valgus stress on to try and drive the radial head up and out the back, and then you put axial compression on. And if you do it right, you'll dislocate their elbow. But in the exam or in the clinic, what are you going to do? You're going to ask them about things that they do that might reproduce this. And a press up, or lifting yourself up out of a chair. I haven't got a chair with arms on, but Pushing yourself out up off a chair is exactly the same movement, okay? So you can do that in the exam, and they will be apprehensive and say, I don't want to do that, or that doesn't feel right, okay? So that's all you need to do. Does that make sense? Exactly like that. There we go. But don't try and lie them down on their back and do a posterolateral rotator instability test. I think you'll find that really difficult and you'll get in a mess. Do this. Of course, don't forget the neck, the shoulder, the wrist, and the wrist and a neurovascular exam, just as Mr. Shahani said to you before. So in a quick overview, stand your patient, have a look around the front, the side, the back. Bring their arms out to the side, have a look on the medial side of the elbow. Do your range of movement. Pro and supination. Feel lateral, posterior, medial, anterior, and do some instability tests, and you've done your exam. And you can get through that in a matter of seconds and have plenty of time to talk then, okay? Thank you very much.
One question again, yeah? One question. Any burning question? Once we get the next speaker on.
Hi.
Is there any importance of the old Cousins test for tennis elbow, which was just resisted wrist cross deflection?
So my opinion is, okay, that's quite a sensitive test as well. And if you demonstrate there's pain on the lateral side, you bring the arm out and extend the wrist, that's good enough. I'm not concerned about you particularly doing the middle finger, but you talk about that to your examiner, don't you?
Thanks, Ben. Hi, I'm Joe Garcia, and I've been asked to demonstrate examination of the wrist and hand today. I always find this a little bit difficult to do in such a short time, unlike the previous speakers who deal with just one joint. I have to deal with multiple joints. They're all little. So we've got multiple anatomical structures. And any of those structures can be involved in some disease process, leading to lots of pathologies and lots of diagnoses that you may need to make either in the clinic or in the exam situation. So there can't just be one examination of the wrist and hand. That would just take too long and be too complex. So even though the wrist and hand is complex, we need to make examination of both of these structures as simple as possible. And the way we do this is by screening. We need to screen, we need to look for any clues, any suggestions of the underlying pathology that we can then focus the rest of the examination on. Looking, not just casually, but observing carefully to see if there are any features of a particular diagnosis is incredibly important. Okay? Fortunately for us, that's the first part of our examination. And we can do that starting by looking at the hands side by side in these three positions. We can look at the hands with the palms facing up. We can look at the hands with the palms facing down. And then we can look at the profile of the forearm, the wrist, and the hand. Not like this with the fingers clenched, but with the fingers extended. Okay? And in these three positions, we're looking for abnormalities. There may be an absence of the normal cascade of the fingers, either with the palms down or with the palms up. We're looking for deformities of the wrist or the fingers, either localized swellings or generalized swellings involving one or more joints. We could be looking for wasting of the intrinsic muscles of the hand or of the forearm. Okay? All these things that we know from very much when we were medical students. I like this particular position because it's so easy to miss certain key clues and findings. And when you look at the profile of the forearm, the wrist and the hand, you might be able to pick up the cubital tunnel scar. You might be able to pick up the presence of rheumatoid nodules behind the elbow. You could pick up forearm wasting. There might be subtle deformities that you've missed in the fingers, but when you look at the profile, you might be able to see the very subtle ulnar claw. Occasionally, psoriatic patches that will go with an arthropathy of the hand. And the other thing that I like about this position is that it makes you stand back from the patient. It kind of makes you stand back sort of next to the examiner, and you can both look, and you can tell the examiner exactly what you're seeing and what he's seeing. So it lets you sort of stand back and sort of observe carefully. It may be that this first part of the screening process actually gives you the diagnosis. But if it doesn't, you then move to the rest of the screening process, and this is the addition of certain movements. Okay? So you can look, and you can ask the patient to put their palms together, bring their elbows up, and you can assess wrist dorsiflexion. You can ask the patient to put the backs of the hands together to assess palmar flexion. And as Ben has mentioned earlier, elbows into the side of the waist, and you can assess supination and pronation. Okay? The nice thing again about this position is that not only are you seeing the range of movement, but you can also assess by the patient's features, their facial features, whether that range of movement is painful, whether it's uncomfortable, whether towards the end range of movement the patient starts to grimace. These are important observations when you're examining the hand. You can then go on to assess the movements of the fingers. Okay, simple. Ask the patient to make a fist, to clench their fingers. Ask the patient to extend. You can then look at the thumb. Ask the patient to flex the thumb into the palm, extend, abduct, adduct. You need to be looking for either complete loss of movement in a joint. You might find there's a reduced joint movement. It might be painful, as I mentioned earlier, or it might be abnormal. In the hand, you might get triggering. You may get subluxation of extensor tendons. You may get subluxation of the joints. These are all things that you need to be picking up on your screening process. In this case here, you can see complete loss of IP joint movement of the thumb. So we're thinking, is this a flexor pollicis longus rupture? Is it a severe triggering where the tendon is stuck? Or it could be a neurological problem. It could be anterior interosseous nerve palsy. Okay? So this screening process is focusing our mind on the rest of the examination. So at the end of it, you have a diagnosis. Great. You may have a differential diagnosis. Or, if you're unlucky, you may not know at all what's going on. And in the exam, the advice here would be not to panic, because in this situation, the patient may be giving you clues, or the examiner may be giving you clues, giving you suggestions as to how to progress. What you want to avoid is complete random examination, which leads you down the wrong path. So don't panic. If you're in the lucky situation where you've got a diagnosis, brilliant, great. You want to demonstrate those features to the examiner. Okay, so in a situation like this, where you've clearly got the diagnosis, you can go on and say there is bilateral symmetrical polyarthropathy, features consistent with an inflammatory arthropathy, the most likely one of which would be rheumatoid arthritis. You can highlight the features that you've seen. Diffuse swelling, radial deviation of the wrist, ulnar deviation of the fingers with MCP joint subluxation, deformities of the thumb, and even the presence of rheumatoid nodules. Okay. Again, another clinical presentation that you might see in the exam, okay? And just careful observation will ascertain that this is a first CMC joint arthritis. You have a prominent base of thumb that which we often call squaring. There's an adduction deformity of the thumb metacarpal. The metacarpal's in the palm. And there's secondary hyperextension of the MCP joint. Okay. You can then go on to assess that a little bit more. You can look at the movements of that thumb, as I mentioned before. And then you can palpate. Here you're palpating for localized tenderness around the first CMC joint. Not anywhere else in the wrist, not anywhere else in the fingers, but you can localize your examination to that joint. And then you might add some special tests. Axial grinding, compression test, although I would warn you just be a little bit careful because those tests would just elicit pain. And the one thing you don't want to do in an exam situation it's caused the patient too much discomfort. We can apply this to other arthritic joints. Again, careful observation here will give you the diagnosis. Fortunately for us, the anatomical parts that we described before are all very superficial. So here, we can see deformities of the DIP joints. There's a suggestion of bony swellings that we know are called Heberdin's nodes. If it's in the PIP, Bouchard's, there might be soft tissue swellings from the inflamed joint or from mucoid cysts. We can look at loss of movement. And a very simple way to quantify this might be the fingertip to palm distance. And again, localized tenderness. I'm sorry. Now, it may be that you've highlighted some abnormality, but there might be a selection of different diagnoses that have led to that. You have a differential diagnosis that you want to assess. This might be the case for finger joint contractures. Not all finger joint contractures in the hand are due to Dupuytren's disease. On the palmar aspect, you can get scars in the skin from previous injuries, from burns, that will give you a contracture. Yes, you can go to the layer below, to the palmar fascia, and contracture of that, Dupuytren's disease, will lead to this clinical picture. But you can go deeper to the flexor tendons, and tendon adhesions, contractures due to previous injuries or infections can give you a very similar picture. The joint itself could be at fault as a result of ligamentous injuries, like the volar plate or collateral ligament, or as a result of arthritis. And even problems on the extensor side, on the dorsal side, an extensor tendon injury or a neurological problem affecting the extensor tendons can give you clawing contractures of the finger joints. So where would you start? Well, looking, observing, we can tell the examiner, or we can annotate where and by how much the joint is contracted. We can look to see if there's any other clues on the skin with scarring, pitting, the presence of nodules. And then we need to do one specific thing. We need to see whether this joint is fixed. Okay? If it's fixed, then it would suggest the likelihood of a condition like Dupuytren's disease. But it could also be due to flexor and tendon contractures, to ligamentous injuries, and severe arthritis. However, if it's not fixed, if you can passively extend a joint, then you might be looking at an extensor tendon injury or a neurological problem. You have to be careful, though, because those two conditions, if they're chronic, can lead to fixed problems as well. We can use localizing tenderness to determine what the pathology is. Dupuytren's, of course, is rarely painful, and it's unlikely to be tender. But we could have localizing tenderness to the extensor tendon central slit, to the collateral ligaments or the volar plate, to the joint or rounded joint in arthritis, or along the flexor tendon path. If you've got Dupuytren's disease, but you palpate in the region of the A1 pulley and it's incredibly tender, it might be that you've got two problems. So here we go. We've got this in the exam or in a clinical setting, and we've identified a contracture of the MCP and PIP joint of the little finger. There's no scars, but there is pitting, and this appears to be a subcutaneous thickening. When we've assessed it, there's a fixed deformity. But there is no tenderness, but we can palpate that cord. Okay? So in this case, yes, the diagnosis is Dupuytren's contracture. If you do have a contracture, and there's a suggestion that you want to measure the level of that, or the degree of that contracture, you can get your goniometer out. Is this correct? Measuring the PIP joint with the MCP joint extended? No. Okay. You have to measure the PIP joint with the MCP joint flexed. Here's another example of a PIP joint contracture. But there's a subtle difference. The PIP is flexed, the DIP joint is extended. On the palmar side, there was no problems with skin, and there was an absence of cords. Was it fixed? No, we could passively correct it, okay? These things can become fixed over a period of time, of course. Was there any tenderness? Yes, there was tenderness over the central slip insertion onto the middle phalanx. The diagnosis is Boutonniere. Okay. We can think, in any of these diagnoses we make, about carrying out special tests that we know are associated with that diagnosis. What test is associated with Boutonniere's? Elson's test. Okay. We can go specifically through Elson's test because it's much better in a tutorial kind of group where you can get in close. So we'll do that this afternoon. Okay. Here's another PIP joint contracture. Take it from me, the little finger and the ring finger are flexed at the PIP joints. But there's hyperextension of the MCP joints. But the other notable finding here, of course, is this wasting. Wasting of the first dorsal interossei in the first web space, and there's scattering in between all the metacarpals. Okay? So there's wasting of muscles. Wasting of interossei suggests a neurological pathology. You're thinking the differential diagnosis here is an ulnar nerve problem. Could be higher up, could be cervical root, T1, could be brachial plexus, or it could be even higher than that, it could be a central neurological problem. So what does that mean we do with the rest of the examination? It focuses our examination down the route of a neurological examination. Now, I won't go this into more detail because John is going to present that next, but we're really going to be feeling for the patient's feeling now. We're going to be moving to assess the power of either the peripheral nerve muscles or myotomes, and then we've got our special tests. So that was a sort of intrinsic minus, loss of the interossei. The other pattern, the opposite pattern that we can get in the hand is intrinsic plus, where the interossei muscles are tight, contracted, possibly because of an inflammatory process like rheumatoid, an acute injury in the past which led to a lot of ischemia, edema, or it could be neurological. We need to know in that situation how to conduct Bunnell's test. Okay, something that we can do this afternoon, but really in Bunnell's test you're trying to assess the degree of PIP joint flexion in two positions, with the MCP joint flexed and with the MCP joint extended. In a normal hand, the degree of flexion is basically the same in those two positions. In intrinsic plus, when you extend the MCP joint, you reduce PIP joint flexion. Okay? Simple. We can go through that later this afternoon. Here's another clinical presentation that you might see either in the clinics or in the exam. We've got loss of MCP joint extension in the ring finger. It is passively correctable, so it's not a fixed deformity. We need to have a differential diagnosis for that. Is it an extensor tendon rupture? Is it that the extensor tendon subluxed because of a sagittal band tear? Is it that the joint subluxed because of an injury to the joint? Or is it because of a nerve injury, a posterior interosseous nerve palsy? It's unlikely to be that, of course, because all fingers will be affected. But the other thing is, careful observation highlights something else, doesn't it? There is swelling along the course of the extensor tendons and around the wrist. So it's likely that it's an extensor tendon rupture. When you've got an extensor tendon rupture, whether it's EPL or EDC, they might ask you to conduct one more test. What test would that be? If it's not a nerve palsy. You're thinking about future management. You might want to know whether there's an extensor indicis proprius. So you want to do that horn test, okay? where you're assessing to see whether there's extensivus proprius or extensivus minimi, okay? Because you're isolating EDC. You're stopping EDC from working. Good. During your screening process, you might identify this problem, okay? So we've asked the patient to move, and that we've noted that there is loss of dorsiflexion, there is loss of palmar flexion, and there's even loss of supination pronation, okay? And we've also noticed that the patient shows some distress or some pain at the end range of movements, okay? So this means that we now have to focus on an examination of the wrist. So we move to palpation. Look, feel, move. Now, with palpation, we're trying to identify any localizing tenderness, because the position or the area of that localizing tenderness will give us a guide to the possible pathology deep to that tenderness. So we need to know our surface landmarks. And this will take us about 5 minutes this afternoon to go through all the various surface landmarks to the relevant anatomy of the wrist. I'm not sure either. Okay. Well, once we palpate and assess this localizing tenderness, we can go and assess movement in more detail, because we've not assessed radial and ulnar deviation. So we can add that to our examination, and that might give us hints towards the underlying pathology. And then we go to all these various special tests, okay, that we need to know. Okay. We're looking at the Kirk-Watson test, scaphoid shift test for the presence of a scapholunate ligament injury. We can look at ballottement of the distal radial ulnar joint for instability of this joint, or compression for arthropathy of the distal radial ulnar joint. We can look at ballottement between the lunate and triquetrum to see if there's any instability between these two carpal bones. We can carry out an ulnar carpal stress test to pick up problems with the TFCC tears, or ulnar carpal abutment syndrome. And then we can look at the pisiform triquetral joint. It's one of my favorite problems to identify in the clinic, because it's often missed because people forget about the fact that it's there. But simple localizing tenderness with compression of the pisiform triquetral joint can be very painful in the presence of arthritis of this joint. So we're going to go through these tests later on this afternoon, okay, in a little bit more detail in small groups. Good. We do obviously have to know some other specific tests that are associated with hand examination. Here's an example that when we observe the hand, this is a normal attitude of the thumb. Here, the patient can't extend the thumb. And we can ask the patient to place the hand on a flat surface and actually then ask the patient to extend fully. It's not just a matter of extension, it's extension, abduction, it's retropulsion. And the loss of retropulsion will give us the diagnosis of an extensor pollicis longus rupture. And then you might want to assess whether there's EIP present. Okay? Here you can see swelling on the radial side of the wrist. This is the area where the patient's been complaining of severe pain for many months. What test may you consider doing here? Finkelstein's test. That's Finkelstein's test, isn't it? Thumb in the palm, fingers over the top, passively going to ulnar deviation. Patient hits the roof, and you failed the exam because the patient's crying. So you need to be aware about being kind to the patient. And if you do have, you probably wouldn't have this kind of patient in the exam, it's just too painful. But you can do Finkelstein's test much more gently, just by having the thumb extended over the fingers, and then just very gradually, very comfortably going into ulnar deviation. Okay. you may find that when you screen the hand, I normally do it with my middle finger, but I don't want to be rude today. You might find that the normal cascade is absent and the index finger is pointing, okay? And you might find there's a scar in the palm of the hand or some evidence of injury in the past. And then you ask the patient to clench and this finger stays put, it doesn't bend into the palm, okay? What do you do next? Well, you suspect a tendon injury, don't you? So we need to be able to assess FDP and FDS. FDP is easy because all we have to do is isolate the DIP joint and ask the patient to flex that joint. FDS is a little bit more difficult because FDP would flex the PIP joint. So we have to exclude FDP, and fortunately we can do that because it's one common muscle belly with 4 tendons. So if we isolate the other 3 tendons, we can stop FDP from contracting, and that way the only tendon that can mobilize the PIP joint is FDS. Okay? And in fact, the DIP joint is completely floppy. The other important thing that you may be asked to do is not just give the diagnosis, such as here, but you might be asked to do a functional assessment of the hand. So you have to have some tools available and ready to do this. You need to have a coin, a pen, and a key. The coin is useful to assess not just chuck grip, but also when you ask the patient to pick the coin from the table, it requires a degree of dexterity, which you can assess. A key to assess side grip or key grip, and a pen for end grip or pencil. There's one other thing that you can do, is you can ask the patient to grasp your forearm to assess grasping. Okay? So functional assessment may be one thing that you're asked to do even in a case which is so complex that you can't give a diagnosis, but you can still do this. So, in summary, screening is absolutely vital, okay? It may give you the diagnosis almost immediately, and you just have to demonstrate those specific features. It may give you an idea of the differential diagnosis that you then have to go on focused examination on. But if you screened and you've had no idea, start to listen to either the patient or the examiner for clues. Thank you.
Those of you who want to stretch, you can stand up and stretch a minute or two if you want to, whilst we wait for the next speaker, John. We'll leave questions till later, yeah? You don't have to.
Okay, so it's nearly lunchtime. Probably like me, regretting that one extra whiskey and feeling a little bit hungry. But I'm going to take you through a very, very common presentation in exams. I collect patients for our course in Chesterfield that we run, and when the FRCS was in Chesterfield, we got patients. Patients with a peripheral nerve injury are very good for clinical cases, and so you'll almost certainly see one in any exam course you come to. To follow on from what Joe was saying, you will either examine this patient's hands, in which case you'll be doing your screening, you're looking for clues, hopefully spotting something that gives you a direction to go, and then you say to the examiner, I'd like to examine this patient's ulnar nerve, and you go on and do an ulnar nerve examination. The other option is the examiner says to you, examine this patient's ulnar nerve, which is that business where it's great because you know what to do, but obviously you're expected to do it very slickly and efficiently in order to get the marks. In order to achieve peripheral nerve examination effectively, you've got to know the anatomy, and what I'm going to show you is an examination for each of the nerves that hopefully allows you to explain to the examiner what you're doing and why you're doing it in relation to different parts of each of the nerves. There's essentially 3 peripheral nerves, but we'll talk about deltoid and musculocutaneous, the other 2 sort of terminal branches of the brachial plexus a little bit. And just to extend that further, you can imagine or remember that each of the peripheral nerves has a bifurcation, therefore giving you three main parts of the nerve to examine. So as part of your examination, you want tests, sensory, motor, or special, to examine each of those parts of the nerve from proximal to distal. And the important thing with the examination for this is that you're testing peripherally is giving you clues and telling you to what's happening proximally. So you're trying to identify which bits of the nerve are functioning or not functioning. In most cases, the pathology is either a compression nerve neuropathy or a traumatic thing, either stabbing, iatrogenic, plating, Holstein-Lewis, that sort of thing. So, as we've said before, look, feel, move. In this case, inspection is pretty useful and usually can help you guide your examination. I think with palpation and special tests and provocative tests, things that are going to cause pain are generally best done at the end. But it's just important to remember to do them. So if we go through each nerve just briefly, and we can practice them this afternoon, I think the important things for peripheral nerves is to think of the attitude of the hand, where there's muscle wasting, scars, and looking for the splints, because these patients often have got a splint around. So with the radial nerve, looking for wrist drop, the places to palpate, as has been said before, possibly you may want to consider a PIN syndrome and palpate just distal to the lateral epicondyle. And the superficial nerve can be trapped in Wartenberg syndrome at the wrist. This is the key slide for each of the nerves, which if you can commit to memory, you can have a system that you can follow and explain to the examiner why you're doing each bit, and you're testing logically in a sequence from proximal to distal. So with the radial nerve, the only sensory component is the superficial radial nerve. So if that sensation is intact, the superficial radial nerve is intact, and the clue is that that gives you the idea that the proximal part will be intact, otherwise the sensation wouldn't be intact. And then for each of the nerves, we've got 5 tests or muscles to examine. And working from proximal to distal, you have a sequence of testing these muscles, identifying where the pathology is and which bit of functioning. One of the most important cases we try to get, or which is very common for exams, is a sort of Holstein-Lewis. So a patient who's got a posterior scar of the upper arm with a resolving radial nerve lesion is fantastic. So somewhere down this path, the radial nerve is recovering. And we got one of those in 2 weeks, thankfully, on our course. And what you need to do is practice this sequence so that it becomes totally routine and you can work your way from one to the other, testing these 5 muscles. This isn't exhaustive, and often we get asked, well, what about this muscle or what about that muscle? But the idea is that you have a sequence that you're clear in your mind that by testing brachioradialis and extensor carpioradialis longus, you're testing the main trunk of the radial nerve before the posterior interosseous nerve comes off, and then working down. And as I say, we'll do this afternoon, where you can practice on each other and the sequence of brachioradialis, extensor carpioradialis longus, extensor carpi ulnaris, indicis, and then EPL. And so 5 things. Most of the time in this talk, when I've given it before, I've invented 2 or 3 new muscles, and you probably will do that in the exam yourself. So for the ulnar nerve, with inspection, I think the ulnar nerve probably has most things to see. You've already seen my hairdresser patient here who had a paediatric elbow fracture, who presented with tardy ulnar nerve palsy. She's been to exam courses. She has the cubitus valgus and a cubital tunnel scar. So she's a fantastic case, and then you go on and examine the nerve. We'll look at the attitude of the hand with these 2 things in a minute, and obviously you're looking for first dorsal interosseous wasting. I think it's really difficult when you do the screening, and what I find people tend to say, there's a little bit, possibly some wasting of the dorsal interosseous, and obviously, and it can be difficult to get the clue. you know, elderly people's hands, there's often looks like there's wasting. And trying to decide whether that's relevant or not, it can be difficult. Wartenberg sign is supposed to be an early sign of ulnar nerve dysfunction, the little finger escape sign. And so if you see that, you can mention it and understand why it happens, and so you can explain to the examiner which muscles aren't working and why you've got the deforming force. This is a favourite in the exams. It's a favourite for getting wrong, and it's fantastic to trip yourself up over. And you need to talk to the dog, the mirror, anybody who'll listen, and repeatedly explain what clawing is and why it occurs, and what the ulnar paradox is. Again, we could talk about that, but you need a phrase, one of these phrases, to try and be able to be clear in your mind. Everybody seems to get confused with the ulnar paradox or discuss whether it is because the nerve is getting better and the clawing gets worse. It is also, that's the same as saying it's a high or a low lesion. So it really is the same thing, the paradox, the fact that when FDP starts working, the clawing gets worse. So if you have the lesion is high, then you get less clawing because FDP is not working. But explaining that can be quite tricky. So for the ulnar nerve, there are a few classic examination things, and sensation is one of them, whereby you examine over the dorsum of the fifth metacarpal and you examine the tip of the little finger. If the sensation is present in the dorsum of the fifth metacarpal, but not in the tip of the little finger, it suggests that the pathology is in Guillaume's canal or distal to where the sensory branch comes off. If they're both affected, then it's perhaps more proximal. And again, you've got 5 things to do, which will test the trunk before Guillaume's canal, in the hand, and then the classic test of Frohman's test. So you can have a sequence which flows down the hand of testing flexor carpi ulnaris, testing FDP to the little finger, abductor digiti minimi, first dorsal interosseous, and crucially you can see palpating the muscle as well, and then go on to demonstrate Frohman's test. And you can say to the examiner that why you're doing each of these and which bit of the nerve you're testing. Frohman's test is again something you need to be able to perform and, as been said earlier on, demonstrate to your patient what you want them to do and explain to the examiner why flexion of the IP joint of the thumb is a positive test because they're recruiting the anterior interosseous nerve. This traditionally was done with Le Monde, but more recently it works much better with a clinical examination book with Ali written on the front. But anything like that will work. For the median nerve, carpal tunnel scars are incredibly common, but quite difficult to see, so look for those. Abductor pollicis brevis wasting is the most likely thing you're going to see, and they may have splints. It's worth thinking about all of the scars proximally in the arm that are relevant for these nerve injuries, because, again, we bring those to the exams. If they've got a scar, either traumatic or surgical, that can be the same thing, and peripheral nerve lesions, they're very good for cases for the exam. And thinking of palpation in the proximal arm where there may be compression of the median nerve. So for the median nerve, you can differentiate whether the problem is in the carpal tunnel by sensory testing in the tip of the index finger or the base of the thenar muscle, in theory. And then by testing these 5 muscles, you can differentiate where along the course of the median nerve the problem might be and which bits are working. So FCR and FDS in the forearm, opponens and abductor pollicis brevis in the hand, and then the OK sign for the anterior interosseous nerve. And again, the OK sign, you need to be able to explain what the positive finding is and why, when you ask the patient to pinch, the IP joints collapse into extension because they aren't able to use FPL and FTP to the index. So, in summary, if you have these in your head and you get asked specifically to examine one of these nerves, you have a routine that you can follow rather than, as Mr. Garcia said, a sort of random scattergun approach to just examining some muscles. This gives you a system whereby you can do things in order and there is a reason for doing the things in terms of where the pathology is in the nerve. For any junior members here, who I'm sure many of you have already worked out this and perhaps used it in your clinical practice, certainly for young children with supracondylar fractures, that sort of thing, just by asking the patient to point across their finger and do the OK sign, which generally children can follow you do, you can do a very gross screening of the nerves. And just to finish, just remind you of the essential anatomy and the other two peripheral nerves, the axillary nerve with the regimental badge area and testing deltoid, and the musculocutaneous nerve if you've got loss of sensation along the lateral border of the forearm, and a scar from an anterolateral approach to platar humerus, then it may be a musculocutaneous nerve problem. Thank you.
Any burning questions related to clinical examination before I explain what we're going to do? Any burning questions? Or you can ask them in the afternoon. Okay. The plan will be to, we'll put a Stan, these are three, group 1, 2, and 3 will be on this side. These are for core trainees, ST3 and ST4s. Yeah. So if you fill it out on that side, on this side, group 4, 5, and 6 will be the more senior trainees who are peri-FRCS, and some people here are more senior. They have their exams and so on, are senior. For example, they've come for they teach clinical examination, or they're here for revalidation with regards to medical legal practice. Then you can hang around with the senior trainees. And obviously, when it comes around, you don't need questions, so you can identify that you won't be quizzed. The whole aim on a Friday afternoon, the end of a BOA, is not to make it stressful for you, to make it enjoyable. So you stick together in pairs and practice your examination. Nobody will be given a hard time unless you specifically want to be quizzed at the level of the FRCS, or we will do that for you too if you want that. Okay, so we're finished about 10 minutes early, so that's great. So if you come back at 1, fill in these forms, okay?
Junior guys, please this way.
And then come back at 1:30, and we all want to finish by 4, okay?